Hi, it's Dr. Robert Brueck coming to you again with another segment, What's New in Cosmetic Surgery. Today I'd like to talk a little bit about breasts, breast augmentation, breast reconstruction with fat. It certainly is one of the more popular operations that we do. And also, if any of you have any questions or you have issues you want to discuss or questions about new techniques, procedures, whatever, you can contact me at 239-244-2329 or go to my website and email me and I'll be happy to discuss it with you. One of the things that a lot of patients ask when they come in for breast augmentations, what is the best incision? Now there's several incisions that different surgeons will use. One might be the periumbilical, which I think is probably less than 5% of the surgeons will still use that incision, because through that incision around the belly button you can only use a saline implant. And I've seen some people that have had it done and frankly it would not be the kind of work I would want my name associated with. Another one is the transaxillary incision. I again don't use that incision because, again, in the axilla, if you get a bad scar, you kind of buy it. And no matter where you make the incision, no matter who makes the incision, there's always going to be a scar associated with it. And I think that's probably one of the biggest misnomers people have regarding plastic surgery is that, well, if I go to a plastic surgeon, I won't have a scar. Everybody gets a scar. The third type of incision is a periareolar incision, and that's an incision that goes around the areolar complex, usually around 50% of it, like from 3 o'clock to 9 o'clock. And I would probably say that's the second most popular incision. I generally don't use that incision. If a patient, and I just did a lady recently who had a periareolar incision, we utilize that same incision so as not to create a new scar. The fourth type of incision is an inframammary incision, that is on the underside of the breast, which is the one that I use probably 95% of the time, and it certainly is without question the most popular incision by plastic surgeons. Now, why is it so popular? Number one, it gives good visualization of the breast, and through that incision you can go on top of the muscle, under the muscle, but it gives good visualization. And the other thing, and I think it's a key point, is the fact that you're far away from the nipple, because the nipple really, in the nipple areolar complex, is the dirtiest part of the breast. And I'm going to discuss in a little bit the whole idea about biofilm and breast contraction and the like. So I generally will use the inframammary incision. It gives me good visualization of the pocket, and I think at the same time probably gives overall the best result. The other nice reason I like that incision is it's on the underside of the breast, and one of the things that modifies scars very favorably is pressure. So if the incision is on the underside of the breast, when you wear your bra and you have a strap, you can put, for example, silastic gel sheeting over the incision, and then your bra can exert pressure over that incision to maximize the cosmetic outcome of the inframammary incision. So for that reason, I prefer the inframammary incision. And I think, again, among most plastic surgeons nationwide, it's probably the best and the most popular and the most used incision. Second thing I want to talk about is fat grafting to the face. I would say if I had to list some of the top trends in plastic surgery over the last 4, 5, 6 years, fat grafting is certainly probably on top of the list. It has revolutionized what we do, and particularly for me, whether it's fat grafting to the breast, which I'll talk about in a few minutes, or fat grafting to the face. Probably about 65% of the time I will do some type of fat grafting to the face, because when people age, our skin thins, we lose collagen, and we also lose volume, soft tissue. And by utilizing a patient's own fat versus a filler, which is perfectly acceptable, by using their own fat, A, we can harvest more fat, and B, it's natural. It's your own tissue. The one negative to fillers is, yes, they will fill the deficit, but the results will be variable from one patient to the next. The filler's the same for everybody. It's the body it goes into. So there was a study done where a Dr. Schendel, who's out in California, took 10 patients, and he got about 50 cc's of fat, prepared what we call a stromal vascular fraction. It involves, stem cells, fat cells, and he induced or injected, on average, just under 20 cc's of fat per phase. The question that he had, of that volume that I inject, how much of it will survive? And that is one of the things I tell patients. When you do fat grafting, whether it's to the face or to the breasts, the big question mark becomes, what percentage of that fat will survive? Now, I generally tell people 40 to 60%. Well, in his study, even though it was small, 10 patients, he did a volumetric, three-dimensional analysis of the fat and the place or pocket it was placed in. And what he found was just under 70% of the fat survived. So that's pretty good, 70% of the fat in the face. Again, I think it's so critical when we do facial reconstruction. For example, somebody's going to do a neck lift. They have this depression here, we call this the marionette area. So when we do the neck lift, they still have that depression, which masks or unmasks the jowl. So in many cases, when I make my submental incision, I'll put some fat in there to smooth out that transition. So fat is really an excellent tool in reconstructing a face that's aged, that's lost volume, that's lost elasticity. So it really is a great, great tool to use in facial cosmetic surgery. The other thing I want to talk about is, let's talk a little bit about fat grafting as it relates to breasts. I would say now more and more patients are coming in to see me to see what I can do to reconstruct their breasts, both from an aesthetic standpoint, a cosmetic standpoint, as well as a reconstructive standpoint. Many women that come in to see me, and it's part of the mommy makeover, where their breasts were maybe a full C or D cup. They've had 2, 3 children, now their breasts are A or B cup. They have what we call pseudotosis. Again, it's important to understand true ptosis, pseudotosis. In pseudotosis, the upper pole of the breast has lost volume, and it looks like somebody let the air out of the balloon, and it hangs and it droops. But the nipple is still well above the inframammary fold. That's the key issue. If the nipple falls well below that fold, then a patient has true ptosis, in which case they will probably need to have a breast lift or a mastopexy. So one of the things that we try to do when we do fat grafting to the breast is to create a more natural look and shape to the breast. Now, many times women are devoid of soft tissue and they have a significant amount of pseudotosis. I generally don't like to put the implant under the muscle under those circumstances, because what happens is sometimes the muscle contracts, the implant will ride high, and then their natural breast tissue will hang down off of that, and it doesn't give a natural look. So what I do and what I recommend to patients is maybe we should harvest some fat from your flanks or from your tummy and augment your breast with your own fat. I comically tell people it's a two for one. So you get fat taken from an area of the body where you don't want it, your tummy, your flank, and you put it where you do want it, your breast. So what I'm able to do is place the fat strategically in an area where I want it. So that upper pole that was kind of deflated, I can put fat there. Also along the sternal area to give the patient more cleavage. It's a great way to restore a more aesthetically, cosmetic pleasing breast augmentation. And it really, really has been outstanding. Now, in some cases, people will come in, they've had implants done maybe 20, 30 years ago. I had a lady recently who was a stewardess at American Airlines. She was mid-60s, and she had them in for 23 years. They were rock hard, and she said, "Dr. Brueck, just get rid of them, take them out, I don't want them anymore." And I said, "Barb, you got to be careful, because I take those out, you're going to have 2 sacks or bags of skin that aren't going to be very aesthetically pleasing, and it may be disturbing to you and your self-image." I said, "Have you ever considered taking fat from your abdomen and your flank and using that to restore some of the volume to your breast?" So she looked at me kind of in an inquisitive way, and she said, "I didn't realize you could do that." I said, "For sure, why not?" So what we did was we harvested fat, about 600-700 cc's from her abdomen, and we took out the implant, cut away the scar tissue, and we augmented her breast with her own fat. Granted, she's a little bit smaller, but she's so thrilled. Now her breasts are soft and natural. She doesn't have that hesitancy to hug anybody anymore, because before they were like rocks. And she was kind of embarrassed when she would hug somebody that, she had these two rocks. But she doesn't have that situation anymore. And so we got rid of some of the fat in her abdomen, so her clothes fit better, she looks better. And we restored some of the volume in her breast. So it's a great adjunct in terms of aesthetic cosmetic surgery of the breast. We also do it a lot in breast reconstruction. Now, there's been some controversy about whether or not autologous fat can enhance a recurrence of breast carcinoma. Back about 3 years ago, the American Society of Plastic Surgeons did an exhaustive literature review and reviewing and surveyed thousands of their members about this, and the net result was that it was safe, and that there did not seem to be an increase in the recurrence of breast cancer among women who have had autologous fat. Now, one of the advantages that autologous fat has in women who are having breast reconstruction, many of them have had radiation. Now, one of the things that happens with radiation is women get radiation fibrosis. So the blood supply to the breast tissue area is minimized. So by adding fat to that area, you can help restore and reverse some of the damaging effects of radiation fibrosis. Sometimes too, women will have a breast reconstruction. They'll have an expander placed, they'll have an implant placed, but they might have concavities or asymmetries as a result of loss of soft tissue secondary to the mastectomy. So we harvest the fat, we're able to do autologous fat to create a more symmetrical breast reconstruction. So it's a very powerful tool, and as we gain more and more knowledge and experience, we're developing new ways to harvest the fat, process the fat, but there's no question, I think it's a very bright spot on the horizon as far as breast surgery, both aesthetically and for reconstruction. And again, I'm seeing more and more people. What's amazing is a lot of women say, I didn't know you could do that. So it's something to think about if you're contemplating breast augmentation. I recently did a lady who had saline implants in for probably 20 years or more. She didn't want them anymore, and so I harvested fat, and we put the fat in there, and now she has softer breasts. She doesn't have the stigma of hard breasts as a result of the implant. So it's food for thought going forward. One of the other things I want to just touch a little bit on encapsulation with regard to breast augmentation. One of the things I tell everybody, when you put an implant into a breast, 100% of the time, you're going to get a capsule. Now that capsule is your body's normal response to a foreign body. So whether it's a breast implant, it could be a knee replacement or a hip joint or whatever, when you put a foreign body into someone's body, their body will form scar tissue around it 100% of the time. The key in breast augmentation and breast reconstruction is to try and keep that breast soft, that capsule soft, because breast capsules have what we call myofibroblasts. Now this is a type of cell that can contract. So as those cells line up like tin soldiers and they contract, it squeezes the implant and it gets hard. Many times women will come in 3, 4, 5 years after breast augmentation and they'll have an asymmetry. 9 times out of 10, the asymmetry is due to more encapsulation on one side than the other. They don't always encapsulate the same. So one of the questions is, what causes encapsulation? Again, it's a normal response. But one of the theories behind severe, tight, rock-hard encapsulation is the idea of a biofilm. What a biofilm is, as the implant is introduced into the breast cavity, it gets contaminated with skin bacteria. For example, staph epidermidis is ubiquitous. It's all over our skin, our breasts, our chest, our face, our arm. And so as the implant is being introduced through the incision, inframammary, periareolar, whatever, the surface of the implant gets contaminated with this bacteria. And then over time, it creates what we call a biofilm. It's a mucopolysaccharide encasement, if you will, of the implant populated by multiple bacteria. This can lead to chronic inflammation and hardness. So that's one of the reasons I prefer to use an inframammary incision versus a periareolar. Because going back to what I said earlier, the nipple-areolar complex is one of the most heavily populated bacteria-wise areas of the breast. Another thing that I do when I do a breast augmentation to minimize encapsulation is to go ahead, irrigate out the pocket with triple antibacterial solution. Again, with the intent to minimize the formation of a biofilm and hence to minimize the chance of getting severe encapsulation. So a lot needs to be done, more studies are being done, more research is being done, but those are some of the reasons why I use the inframammary, some of the reasons why people, for example, will get hard encapsulation. Some of the other things that I've noticed over my 37 years, women that are very thin tend to form harder capsules than women that have a nice soft tissue cuff. What the etiology is or the reason for that is, I don't know. Women that have, for example, unsuspected or untreated hematomas. In other words, a woman has a breast aug, she gets some bleeding, she gets a hematoma, but it's not taken care of, it's not evacuated. Many times those people will go on to develop hard encapsulation. So it's important, should that occur, that the hematoma is evacuated, the bleeding is controlled, and you do that to minimize hard encapsulation. So again, I want to say thanks so much for spending time with us. Hope we gave you some insight into different aspects of fat grafting, breast surgery, and the like. Again, if you want to call for a complimentary consultation, call me at 239-244-2329. Or go to my website, Beauty by Brueck. We have an online link that you can do an online consultation with me. And again, we look forward to any comments, any questions that you'd like me to address in future issues and future episodes. Wish you and your family a wonderful week, the richest of God's blessings to all of you, and thank you once again.